Coming soon, our new bespoke learning management system will host podcasts, an online version of the famous SICOT diploma exam, virtual training modules, surgical technique courses, a discussion forum, and much, much more. We hope you'll join us on this pioneering journey as we push the boundaries of what is possible in online orthopedic education together.
Hi, good morning, good afternoon, and good evening, ladies and gentlemen. Welcome to the SICOT Pioneer Webinar Series. I'm Dr. Margaret from Hong Kong, Chair of the SICOT Education Academy. Before introducing today's chair and faculty, I would like to share some background on the SICOT Pioneers Initiative. SICOT Pioneer is part of the SICOT Education Virtual Platform, which launched in June 2020. Since its inception, we have organized over 92 webinars and 6 TED-to-TED sessions. To date, the platform has garnered over 47,000 live views and another 77,000 on-demand views. We are also proud to have a pioneer fan club of just under 10,000 members. If you would like to explore our previous webinars and other education activities, please visit the SICOT website at www.sicot.org. We encourage you to join as a member to access these resources on demand. Today's webinar is organized by our Foot and Ankle Committee. It is about one of the important foot and ankle injuries, which is the Lisfranc fractures. Our moderators is Dr. Moez Ballal, who is the consultant foot and ankle surgeon in Abu Dhabi, UAE. He is the vice chair of the SICOT Foot and Ankle Committee. So without further ado, I'll now hand over to our moderator, Moez, to begin the session. Moez, please.
Thank you so much, Margaret, for the introduction. Let me just play. So I hope you can see my slide. Right. So our topic for today is Lisfranc injuries from anatomy to fusion. I'm really excited that you're going to be joining us for an interesting topic and with a fantastic faculty. So we have Labidi from the UK, Amit Patel from the UK, Luckshmana Jeyaseelan from the UK, Manuel Monteagudo from Spain, Pradeep Moonot from India, and Zongxian Li from Singapore. We'll be covering a few topics. We're starting with anatomy and classification. Then we're going to go ahead with examination and assessment and open reduction into fixation, to fuse or not to fuse, that is the question. And then suspensory stabilization, the experience of Pradeep Moonot, and a case discussion. I'm going to quickly introduce the faculty. So Labidi is a consultant foot and ankle surgeon who currently works in the University Hospital of Birmingham. She's the first female trauma and orthopedic surgeon in Croatia before moving to the UK. She's the educational lead. She's the BOFAS committee member and SICOT Foot and Ankle committee member, and she speaks 5 languages. Welcome, May. Second is Amit Patel, who is a consultant foot and ankle surgeon and works at Bart's NHS Trust and the University College London. He's the vice chair of the youth committee at EFAS and a member of the foot and ankle committee at SICOT. Following is Mr. Luckshmana Jeyaseelan. He's a consultant trauma and orthopedic foot and ankle surgeon. He's the clinical lead of trauma and orthopedics at Bath Health Orthopedic Center. He's the training program director at the Royal London Trauma and Orthopedic Rotation, and he's the past chair of the Foot and Ankle Committee. Then we have Manuel Monteagudo, who is the director of the Orthopedic Foot and Ankle Unit at the Hospital University in Madrid. He's associate professor in orthopedic and faculty of medicine in the UAM Madrid, Spain. He currently serves as the president of the Spanish Orthopedic Foot and Ankle Society, Sports Medicine and Surgery of the Foot and Ankle, and he's on the scientific committee of the European Foot and Ankle Society as a chairman. He specializes in foot and ankle disorders and sports injuries. Then we have Pradeep Moonot. He's a consultant orthopedic surgeon who specializes in foot and ankle surgery and sports medicine. He's the foot and ankle surgeon to the governor of Maharashtra and a committee member of the American Foot and Ankle Society, and the ex-joint secretary of the Indian Foot and Ankle Society. And he works in several hospitals in Bombay. Last but not least is Zongxian Li. He's a consultant foot and ankle surgeon, currently based in Singapore, and he works at the Singapore General Hospital. He's also the clinical assistant professor at the Sing Health Duke NUS Medical School and a clinical lecturer at the NUS Yong Lu Lin School of Medicine. His interest includes general orthopedics, trauma, minimally invasive, and endoscopic foot and ankle surgery. So that's the faculty briefly. So without further ado, we will start with the first topic, which is anatomy and classification of Lisfranc injuries by Labidi.
Thank you. I'll just need to share. If you can stop sharing, please. Thanks. Yes. Good morning, good afternoon, and good evening, everyone. As we say in the SICOT community across the world, so I'll be talking about the anatomy and the classification of the Lisfranc injuries. Now, first, a little bit about the nomenclature. I always like to investigate and research why is something called that way in classifications or whatever. In any case, so the Lisfranc, one of the things that happens quite commonly is that people write it as two words, Lis and Franc. So please stop doing that. So Lisfranc is named after Jacques Lisfranc de Saint-Martin. And he was a military surgeon, a surgeon, also gynecologist, as far as I understand. And the nomenclature actually came in the Napoleonic War in the early 19th century, and it was actually it was defined because of the amputations in that level. It's basically the tarsal-metatarsal joint. Now, the anatomy, so on the left-hand side here, so there is on the left-hand side here, so you have the normal joint and a joint that is injured. Now, this is a very simple image. However, I wished to sort of show this because typically people, especially I would say non-foot and ankle surgeons, they would, whenever they hear Lisfranc injury, it would be automatically something referred to the ligament, which is incorrect. So the Lisfranc joint and any injury can happen, or the Lisfranc can happen in that level. In the middle image here, illustration, it might not be the best one. However, on this one, you can clearly see the intermetatarsal ligaments, and that's important to differentiate that ligaments are not present between the first and the second metatarsal. You also have the peroneus longus ligament, tendon that is attached to the base of the first metatarsal, and that does take part in the stability and the integrity of the first TMTJ, i.e. tarsal-metatarsal joint. On the right-hand side, finally, so it's basically an illustration to show that a cadaveric illustration that shows how the second metatarsal clicks in, i.e. fits in like a mortise between the medial and lateral cuneiform. And that's quite important to know. As we know, it's one of the main stabilizers in that level. Now, going on to the Lisfranc ligament. So on this slide, the Lisfranc ligament is really the one in the middle, the blue one, the one that is defined as the interosseous ligament, and that is the proprius, the proper Lisfranc ligament. The other ones, which is the dorsal ligament, which was earlier known as one of the weakest ones, but recent studies actually think that is not true. So it seems that it does have quite some strength. And the third part, which is the green one, it's the plantar ligament, and as you see here on the cross section, which is on this level here. So it connects the medial cuneiform with the base of the second and the base of the third metatarsal. Now, altogether, it's called the Lisfranc ligament complex, and only the blue one is the proprius Lisfranc ligament. The Lisfranc ligament typically tears with forceful pronation and abduction, and that's when it's tight, and that's one of the mechanisms of injury. Interestingly enough, the Lisfranc dislocation injuries are the most common in the foot region. In this illustration here, you can see a lateral lateral illustration of an axial load, which is one of the main forces that does cause a Lisfranc injury and dislocation. And you see here the second metatarsal is popping out. On the one on the right hand side, so you see the Lisfranc ligament or the complex that is torn, and how you have a lateral slight subluxation, probably rather than a dislocation. Now, this is probably something that my colleague Patel Mr. Patel is going to talk about. However, just briefly on this one slide to touch bases about the flex sign and the step off sign and their importance. So sometimes 30 to 40% Lisfranc injuries are missed. And if we know the generic population, if they know that to pay attention to these fine, subtle signs, then we should be fine, probably. So this is a small bony fragment, as we see, and that's an indicator of the probably avulsion of the Lisfranc ligament. The right picture illustration, you see the X-ray. You see that you have a step here, and that's a step off. That would indicate a dislocation/subluxation. Another method is weight-bearing X-rays that do show diastasis more than 2 millimeter, and that would be an indicator between the first and second metatarsal of some injury to that ligament. Now, going to the second part, which is the classifications. So I mentioned here two main classifications. So interestingly enough, the first ones that are noted were from Cuny and Kuss. I'm not too sure, did I pronounce that correctly? In any case, you can see that it was, they've done this classification in 1909. And only 70 years later did Hardcastle come up with a modification with just more details and Mike Myers. So this is in reality a combination of everything, because the main way of classifying the Lisfranc injuries is to look at the three columns, which is the medial one, the first metatarsal, first ray, the middle one, which is second and third ray, and the lateral one, which is the fourth and the fifth ray. So here you'll see in the next slide the illustrations of this. It's basically three bits: homolateral, complete incongruity, whether it's lateral or medial, doesn't matter. So that's classified as an A. Some would mention that they sometimes have an A1, A2 with a base of first metatarsal fracture or base of second, but that's the variable. Then the B classification is homolateral, so partial incongruity. So it goes with a medial displacement, either a medial displacement of the first ray or a lateral displacement of the second, third, or more when it's complete. And the type C is a divergent type of injury. So it would either go the medial column would go medially, and the laterals would go lateral, whether complete or partial again. This is the illustration of this classification. And this is mainly for high energy injuries. Now, this is the final classification that I'm going to mention, the Valuro. classification, and it is basically for low energy. It's more for a sprain of the indicates the injury of the Lisfranc ligament itself. So you have your type 1 indicates a ligamentary sprain. Type 2 indicates subtle ligamentary injury with diastasis between 1 and 5 millimeters, and there's no medial arch collapse. And the third type finally is more severe, and you would find more than 5 millimeters of diastasis between the first and second, and collapse of the medial arch. That's an illustration of it. And here it's quite nicely, you can see the cross section and how the ligaments from the dorsal to the plantar aspect, how are they affected. And that's it from me. Thank you very much.
So I'm having some issues with the video, guys. Thank you so much, Mai, for the comprehensive description of the anatomy and classification. Next, we're going to have Amit Patel for examination and assessment.
Thanks, Moez. I'll just load up my talk. If you stop sharing yours, Moez, I'll load mine up.
Can you? Yeah, okay, perfect.
So, hello, everybody. I'm going to talk about Lisfranc injuries and their examination and assessment. What we need to remember is that, some of us work in different settings, and that can be anything from a major trauma center to a smaller district general hospital. But Lisfranc injuries come to all of us in different ways and forms. And really, there's two different ends of the spectrum, two cohorts. One is your major trauma cohort with high energy injuries, open midfoot injuries with commonly neurovascular problems. And they're polytraumatic, they've got injuries elsewhere. And the other end of the spectrum is your minor trauma closed injuries, can be subtle injury. They can have limited symptoms, and often they come with a delayed presentation. Now, in major trauma, in a limb-threatening or life-threatening injury, these need to be managed first and assessed appropriately via ATLS and managed by our colleagues. And we've got to remember, some of these people or these patients come with multiple midfoot injuries, not just the Lisfranc injury. So all of these need to be managed appropriately at the same sitting. What you need to be careful of in these patients is the missed Lisfranc in polytrauma patients who've got distracting injuries elsewhere in the body and come back to you as a foot and ankle surgeon 6 months later with midfoot pain and already degenerative changes setting in. I think minor injuries can be the most difficult to assess. Commonly, they may come 4 to 6 weeks after an injury with resolving plantar ecchymosis, which is thought to be pathognomonic of a Lisfranc injury, where you get bruising on the underside of the foot in the midfoot area. And really, these patients need a real careful history. And what you want to ascertain is, can that history match with the mechanism, as May showed us, for a Lisfranc injury, that hyperplantar flexed foot with an axial load and often some degree of rotation as well. Away from those open massive injuries and obvious midfoot injuries, in more subtle injuries, you need to check, is there pain on palpation of the TMTJs all across from the medial to the lateral foot? And is there discomfort when you manipulate the TMTJs, trying to move them up and down in the sagittal plane or rotation at that midfoot? Does that cause pain there? And beware those delayed presentations coming in 6 weeks or more, after their injury, because these are most difficult to diagnose and quite difficult to manage. Radiographs are your first intervention. Your classic DP radiograph, looking at between your first web space, between your first and second metatarsal bases. Often you can see the flex line of an avulsion in this view. On your lateral, commonly in less energy traumatic injuries, you don't often see a dislocation, but it's also very difficult if the radiographer has taken that view in a slightly different view. You're not really seeing all of those TMTJs, so you're not really getting an idea of true dislocation or subluxation with radiographs. What you're looking for are these lines congruent. On the left, we can see the lateral side of the first metatarsal and cuneiform, as well as the medial side of the second and the intermediate cuneiform, and the medial side of the third and the lateral cuneiform. And are all these lines aligned? Or is there, as you can see in the middle image, a step off or a widening of that first Lisfranc space? In our lateral image, you can see you need to then look at an oblique view to look at the base of the third, base of fourth, base of fifth, to get an idea of whether there's been any incongruency in this area. And really, you want to work in a methodical way, medial to lateral, assessing each joint, each line, to see if there's any incongruency. In an ideal world, especially in those delayed presentations, you want to be getting bilateral standing weight-bearing x-rays, because commonly in the acute or semi-acute setting, people can't put full weight on these, and you can't really get an idea sometimes whether that gap is widened compared to the contralateral leg. So what I would do in clinic is request for your radiographers to do a standing x-ray of both feet so you can accurately compare the two. And often this is where you see actually that is a space larger than the other side, and it fits with their history. So let's offer them some management. Finally, I think CT really is our gold standard in these patients. The problem is, I think conventional CT can be challenging. Often, you get a CT not really aligned with the joints of the Lisfranc joints in the midfoot. And so you're trying to decipher which joints are dislocated, which are sublux, which are problems. And in something obvious like this, you are able to see, such as the first diagram on the left, you can see the first TMTJ is dislocated, slightly subluxed. The second TMTJ in the middle doesn't look really normal. And on the lateral radiograph, you can see the third, fourth, and fifth metatarsal bases aren't really aligning with the rest of the midfoot. So in somebody with a really gross incongruency, you can tell what is injured and what needs to be managed. But what I would encourage people to do is have a system and reorientate these slices. So what I do is I look at the first TMTJ. I'm looking for an avulsion fracture to see whether it's stable on the CT, commonly on the sagittal view. I'm going across into the second TMTJ, looking for that flex sign in the gap, and into the third TMJ, looking for a fracture. And finally, are the fourth and fifth congruent? And is there displacement at any point in these joints? In this X-ray on the right, there looks to be a bit of opening in that medial space, but I think a CT is needed. And when you look at the CT, you can reorientate everything appropriately. You can go through each of those joints and see. And we can see in the top right image, there's a slight fleck at the base indicating some instability of that first TMTJ. As you go across to the second TMTJ, you can see that actually it looks congruent. So has the energy of that injury gone across into the second? But we can see the third and the fourth are injured as well. So we suspect the energy of the injury has gone across all of that Lisfranc joint into the third and fourth. And you need that oblique view where you can see in the top right corner, the third is fracture dislocated as well as the fourth. So these will need to be managed at the same time. Bit of a word on standing CT. I think access to that isn't universal. And I think the biggest use of that may be in the delayed presentations and getting them weight bearing on both feet in a standing CT. Thank you very much.
Thank you so much, Amit. Next will be open reduction internal fixation by Lucky. Tips and tricks. Over to you, Lucky.
Thanks, Moez. I'll share that. Okay, great. Hopefully everyone can see that on the screen. It's great to be with you guys today, and thank you for attending. We're going to crack straight on, and I'm not going to make any apology for going a little bit over the anatomy again, but some key points. We get obsessed when we look at Lisfranc's at looking at the interval between your medial cuneiform and the base of your second metatarsal. But it's important to remember that the Lisfranc ligament complex actually includes all of your tarsometatarsal joints, all of your intermetatarsal joints, and all of your intercuneiform joints. So it represents quite a wide area for potential injury in the midfoot. What you can see in the middle there is reference to the column theory when we talk about foot and biomechanics. And essentially some important factors here are that length and alignment are key. But with your medial column, which is your festrae, we know there's about 5 to 10 degrees of movement. So its movement is there, but it's not hugely prominent. The middle column is your second and third rays. Now, these are rigid, and there is no movement at the TMTs in this region. And finally, your lateral column, which is your fourth and fifth tarsometatarsal joints. And we know that there can be anywhere between 10 to 20 degrees of movement in both the coronal and sagittal plane here. And so the movement of this lateral column is clinically significant because it helps you adapt your foot to uneven ground. But from an impact on what we do point of view, we don't want to rigidly stabilize these. And so it's important to understand the function of the columns. Like I said, alignment of the columns is important, but length is equally important. And that picture on the right shows you the standing tripod that we have. And what you can see is that relationship between the heel, the fifth metatarsal head, and the first metatarsal head relies upon the correct lengths of your columns. And we can use these principles to virtually manage any type of Lisfranc injury, however high energy they are. And we'll look at some examples. So what's my first tip? And again, slightly going over what my colleague, Mr. Patel, said. This is a 30-year-old gentleman, injured his foot, came in to see us at about a week later. And these are pretty standard x-rays we get from the emergency department, non-weight bearing, 2 views. And to my eye, when I look at this, there's probably or possibly some widening in the 1-2 interval, probably a flex that is, you can see on the oblique there between the cuneiforms, but very difficult to tell. And so one of the key things for me is the importance of that weight-bearing x-ray, because when you weight bear this same patient, you can see the obvious malalignment in the second tarsometatarsal joint with a bit of dorsal subluxation, and you can just make that out on the lateral x-ray with a small step off on the top. So weight-bearing x-rays are important and a pretty standard part of my assessment, especially of subtle Lisfranc injuries. Again, here's another example, standard x-rays, AP, oblique, non-weight bearing. This time they got a CT, and you can appreciate the flex signs that are visible in between your cuneiforms and at your Lisfranc interval there. But really, for me, the other benefit of weight-bearing x-ray is to get the other side, because it really kind of draws your eye to the affected side and shows you where the abnormality is. Similar picture, just again showing you where the abnormality is here on the left side. So moving forward to a few other important things that I think are relevant. Stress views. Now, when I was a resident, we used to talk about stress views as a way of deciding whether a patient needed surgery or not. Now, I don't think that's necessary with the way that we have advanced imaging techniques, weight-bearing x-rays, and our understanding of mechanism. But every time I take a patient to theatre to fix their Lisfranc, I always start by screening the foot. And in particular, I'm looking at the first tarsometatarsal joint. Now, you can see here, obvious Lisfranc injury, obvious malalignment of the second metatarsal base there. But the first TMT looks fairly congruent here, and it's a nice sagittal picture showing you that it's got a slight saddle shape. And I believe that that gives you some inherent stability when you're not weight bearing. And so it's quite easy to miss instability in the first TMT. When we take this patient to theatre and screen the foot, what you can quite clearly see is that the first tarsometatarsal joint is unstable and needs addressing as well. And so I always start with screening the foot, not to decide if I need to do an operation, but to help me decide if I need to be doing anything to that first tarsometatarsal joint. What about approaches to Lisfranc injuries? Well, there's two mainstays. There's a single dorsal approach that you can put over your second metatarsal. Issues with this are that you have to encounter the neurovascular bundle, which you can see on the left-hand side here. So there is a rate of neurovascular injury, but it does give you excellent visualization of your Lisfranc interval. And here's a nice little trick where you can try passing a McDonald into those joints. And if there's no injury, you shouldn't be able to do that. It's a big marker of instability. And again, you shouldn't be able to get a McDonald in between your first and second metatarsal bases. Yeah, and you certainly shouldn't be able to see any of the articulating cartilage on that middle cuneiform. Having said that, my preference actually is to do a dual incision approach. Now, this is not a great picture, but generally I tend to do a slightly dorsomedial incision to access the first tarsometatarsal joint, and then I do an incision between the second and third metatarsals so that I can address those relevant tarsometatarsal joints. This gives you a big skin bridge, so we don't often see complications with skin bridge necrosis, and it keeps you away from the neurovascular bundle. Okay, so this is generally my preference and what I will use in the examples that you'll see coming up. Positioning, normally I do supine, but more recently, and I know that some of my other colleagues, you can put the knee over a bolster and have the foot and the heel just resting on the bed. And what this naturally does is give you, on an AP X-ray, the perfect view down the tarsometatarsal joints. And so it's quite a convenient way from an imaging point of view. So what about evidence? What do we know? Well, if you take one thing away from this talk, I would suggest it's this, that anatomic reduction is key. We've got a number of papers that have shown that patient outcomes, radiological outcomes, and overall determinants of outcome, the key one is anatomic reduction. Okay, so if you take one thing away, if you get things back where they belong and it looks anatomic, patients will do better. Excuse me. Other areas of controversy, primarily ligamentous Lisfrancs. Now, this is a seminal paper by Chris Coetzee in the American JBJS 2007, and he found in his cohort that in primary ligamentous injuries, so where there's no fracture involvement, these seem to do better with fusions. And this sort of dictated the way we managed ligamentous injuries for several years, really, decades in fact. But there is literature to support that bridge plating can be used as well. And so really, this for me, continues to be a slightly controversial area. What about fixation techniques? Well, transarticular screws used to be a popular choice of fixation, but we know they cause damage to the chondral surfaces of the joints. And we've seen a move towards dorsal bridge plating because that's protective for the joints. And there's now plenty of evidence to show that dorsal bridge plating gives you better functional outcomes than transarticular screw fixation. And so I think, there's good indication to move away from for anyone doing transarticular screws. Having said that, putting plates in means that at some point you've got to take them out, and most of the literature would advocate removing them at some point between 3 and 6 months. And this was a good paper by James Calder that looked at rate of neurovascular injury or neurological injury with a single dorsal approach. And he found that there was an 11% risk of injuring the deep peroneal nerve when doing the initial operation. When you had to remove the metalwork, that jumped up to 23%. So this is not an insignificant thing, having to remove the metalwork. The healthcare system that I work in means that often we are not able to get to patients as quickly as we want. And so we had a cohort of patients that had their metalwork left in situ. And when we looked at the outcomes compared to those that had plates removed, we found that they were pretty equivocal and no significant difference. Now, the one thing that you must remember about the literature in Lisfranc injuries is that there's no really strong robust level 1 evidence. Most of it is experienced, consecutive patients within groups. So it's important to remember that really you've got to take each patient on their own merits and look at the injury patterns individually, understanding what exactly has been involved. So let's go through a few cases and look at a few examples. This one is fairly straightforward. On your non-weight bearing and on your CT imaging, you can clearly see there is widespread tarso-metatarsal joint malalignment and subluxation dorsally. And you can see that nicely on the 3D recons on the right-hand side of the screen. So we know that we need to be stabilizing the main columns. Okay, so for me, that involves doing medial plating or dorsomedial plating of the first tarso-metatarsal joint, and then dorsal bridge plating for the second and third. We talked about the fact that the fourth and fifth are mobile joints, and they often, once the 1 to 3 is stabilized, they will often fall back into place quite nicely. Now, one of the common mistakes I see from my trainees with this type of approach is that they'll often put all the bridge plates in before that Lisfranc screw. And what did we say? Well, we said that anatomic reduction is key. And so really, from my point of view, once you've stabilized that medial column, the next step is to bring that second metatarsal base back into that arch, back into the keystone before you position any of your plates. Okay. Here, another example. Obvious fracture to the base of the second metatarsal here. And with our 3D imaging, you can see, excuse me, the first tarso-metatarsal joint looks fairly congruent. T-shaped split in the base of the second, and there's a fracture at the base of the third as well. 3D imaging can often be helpful, and reconstituting your CT images can give you a lot of help in understanding injuries. But the key thing here is when you take this patient to theatre and screen their foot, you can see that first tarso-metatarsal joint is unstable as well. And then that helps you dictate that you need to stabilize the first TMT with a bridge plate and carry on as we'd previously described. I didn't want to just use all my examples of a dual approach. This is one of my colleagues. Obviously, Lisfranc injury, fractures to the base of the second and the base of the third, and dorsal subluxation, as we've talked about, of the second in the top right-hand corner and the third in the bottom left. So here is that single approach. Here's a demonstration of that instability with that McDonald, as we talked about. And again, here you can see the dorsal step and the instability quite easily revealed. But whichever way you go, the treatment is the same. You've got to get that second metatarsal base reduced into that keystone, and that's where you start. And then you can go on to add your bridge plating, which in this case tends to all be dorsal, and you can stabilize everything with good anatomic reduction, which we know gives the patient the best chance of success. Here's one that Mr. Patel was talking about earlier. You can see here, obvious fracture of the base of the second. But look out for those tarso-metatarsal joint avulsions that you can see on the left-hand side of the screen. There's an avulsion at the lateral side of that first tarso-metatarsal joint. And so we know excuse me, lateral and plantar side, we know that first tarso-metatarsal joint is unstable, as well as the second base fracture and the third. And so again, standard recipe for me, bridge plating, anatomic reduction. I just wanted to finish on some more complicated injuries. We see a lot of high energy injuries, as I know my colleague Moez does in Abu Dhabi. And these can be quite daunting. You can see the cuneiforms are all off. The metatarsals are almost plantally subluxed. The medial cuneiform is dislocated and pressing on the skin. And it can be daunting to understand how to manage these. But really, if we stick to our principles of length and alignment, really, it's restoring the column lengths. And the best way you can do that in this context is bridge plating the unstable joints. This helps get everything lined up. It helps provide stability to the midfoot. And overall, it gives this patient the best chance for success. And again, another example, really quite daunting here. The midfoot's completely smashed up. There's obviously a lateral column injury, and you can see the incongruity at the lateral tarso-metatarsal joints. And really stick to the principles, length and alignment of each of those rays, each of those columns. And what you can see here is the first TMT was stable, There was a fracture through the medial cuneiform, which is where that medial column break was. We've bridge plated with quite low profile plates, and we've done a lateral column bridge plate. Now this will have to come out at some point because we want those to be mobile, but it certainly allows everything to consolidate and heal. So I hope that was useful. I've shared some of my experience and cases, and hopefully we'll have some time for some discussion later in the webinar. Thanks very much. Moez, I'll hand over to you.
Thank you so much, Lucky and Amit, for two fantastic talks that seem to be complementing each other. Next is to fuse or not to fuse. That is the question. Over to you, Manuel.
Well, thank you very much. Thank you for having me. I will share my screen now. Got full screen in a minute. Here I am. Good. So, to fuse or not to fuse, that is the question. There are different settings in which we could consider fusion to the Lisfranc joint. One of them is the acute, subtle, non-subtle setting. Most of the times we go for a internal fixation of this joint when we have injuries, acute injuries, but severe injuries may be also an indication for primary fusion. In the end, most of our cases, when they are severe cases, will end up in a fusion. So there's quite a lot of papers out there saying that apparently primary fusion do as well, at least as well as internal fixation initially. So now our threshold for fusion of the Lisfranc in severe injuries is lower and lower. So apparently there's also some research saying that primary fusion and secondary fusion for Lisfranc joints are apparently as good as well. So again, we might consider primary fusion in the setting of a severe comminuted Lisfranc injury. Obviously, the chronic neglected post-traumatic arthritis is the ideal setting to plan an arthrodesis. Most of these times, this condition, this scenario in which there is an involvement of the first, second, and third TMT joints, and usually with abduction and foot collapse. So a remodeling fusion is necessary in these cases to restore mechanics and restore anatomy. And then we usually go for remodeling wedging medially and wedging plantarly to correct this setting of abduction and collapse, which is so invalidating for our patients. We used to get so much metal work, so one of my mentors said that get as much metal work as you can so that nobody can spot the non-union. But we know this is a difficult setting in a way. Some of the new developments in implants made our life easier, as we can get more primary stability to these secondary fusions. Most of our patients in this setting are not that much compliant, so we need to get as much primary stability as we can from our remodeling Lisfranc fusion. And I wanted to draw your attention to the so-called primary central arthritis. It's been a topic of my interest and research for a long time. Most of our books say that there's a primary arthritis to the Lisfranc joint affecting the second and third TMT joints. And even the industry have designed these funny plates for actually fusing the second, third metatarsus, the second and third cuneiforms. But some of these patients never recall any type of even subtle Lisfranc injury in their lives, and that was a mystery to me for a long time. Still, for those patients, Lisfranc arthrodesis was the gold standard, but it was prone to non-union. It was technically very demanding. You were prone to have nerve injuries, and it was easily associated to a long time non-weight bearing in the post-op. So most patients were not fully happy. You couldn't expect a Christmas presents for these patients because they were not really happy with that procedure. And even those cases in which we had a solid fusion, they were not happy with the stability and residual symptoms of the Lisfranc joints. So it is in the end an asymmetric arthritis. I'm sure you have the experience when you're trying to fuse the second or third TMT joints, that you do a dorsal approach, get away from all the osteophytes, start walking on the joint, but then at the middle aspect of the joint, then you have virgin cartilage in the plantar aspect of the joint. So the Lisfranc, central Lisfranc joint is worn out in the dorsal aspect, but it's apparently intact in the plantar aspect of the joint. So we do believe it is not a primary, but a secondary mechanical problem there. Most of our patients have a combination of tricep tightness and a sulfus metatarsal or a metatarsus adductus that will compromise the dorsal Lisfranc joint in the central area. You can check tight gastros by the Sylvester test, and the sagittal plane when you have a tight gastrocnemius, there are two ways to escape from equinus problems to the dorsal Lisfranc. One of them is pronating the foot. Most people have a foot collapse, usually do not develop central arthritis, or the patients can adopt a bouncy gait, external rotation, to escape from dorsal jamming of the central Lisfranc. Some of these creatures who adopt this bouncy gait and they walk with flexed knees never develop arthritis in their midfoot. So those patients who cannot compensate, cannot adopt a pronation or a bouncy gait, they do suffer from dorsal jamming of the Lisfranc. On one hand, they have attack gastrocnemius, and that will cause several problems, which are not, I believe, casual. Non-Achilles insertion tendinopathy, plantar fasciopathy, and dorsal central Lisfranc arthritis in many of them. These patients usually present with a sulfus gastrocnemius, so moments of forces are driven to the second and third TMT joints, so they develop dorsal jamming and arthritis to the second and third. Some others have a metatarsus adductus, and it is the same mechanical problem, and they develop second and third TMT arthritis. There are other models in the literature developing asymmetric arthritis in the midfoot, like Muller-Weiss disease. If we have a dorsal jamming and we have an asymmetrical wear on the dorsal Lisfranc, this is something that we are able to observe when we're operating the dorsal Lisfranc joint. Is there any alternative to an arthrodesis? Well, we're quite familiar to this type of asymmetric arthritis in the ankle. So many of us will think of supramalleolar osteotomy in this case, but think of the sagittal plane for that. Can we save the Lisfranc joint? We've been working a lot on this, and we believe the combination of addressing these two problems, the proximal gastrocnemius release and acting on the forefoot, can get patients away from arthrodesis. So we start in these patients through performing a proximal middle gastrocnemius release, cutting the fascia of the middle gastrocnemius, and then we proceed to the harmonical sorting of the lesser metatarsals. So the mechanics are then restored, and forces will go through the first TMT joint rather than the second and the third. These patients get a lot of pain relief, and we're about to publish our series on 10 patients with more than 4 years follow-up, and they're happy with the procedure. No arthrodesis has been needed so far, and this is much better, easier than an arthrodesis to the central Lisfranc. So my take-home message would be, a primary arthrodesis versus internal fixation is also a topic of interest. Some primary arthrodesis might be needed in case of severe injuries. The so-called primary arthritis of the central Lisfranc is possibly of a mechanical origins, and our patients usually saw that gastrocnemius and sulfus metatarsal as the more common combination. So if it is secondary to a normal mechanic, we can restore mechanic. We can avoid arthrodesis in most of these patients. So Lisfranc arthritis is not always equal to the need of performing an arthrodesis in all of our patients. Thank you very much.
Thank you so much, Emmanuel, for a really interesting talk. I'm pretty sure there will be lots of questions on that. Next is Pradeep. And why have you stopped using suspensory stabilization?
Okay, so can see my slide.
You just need to click share. Yes.
Okay. Sorry. Thank you very much, Moez and SICOT, for giving me this opportunity. So my talk was my experience on suspensory experience and when I stopped. Actually, it should be when I use it or when I do need to use it. So these are how we would be doing it. Introduction, Lisfranc, everybody knows, and we've been talking about it. And because of the increasing awareness, we've been recognizing Lisfranc's quickly and nicely, and also having surgery done. Also, high incidence in athletic or trauma populations who still need active joint motion. And we heard from the previous speaker how fusion can be done, but would you do a fusion in athletic patients? And there is a shift in fixation philosophy over the past decade. But the key thing, as Lucky said, anatomical reduction is the key. You want to get a stable fixation and you want to allow early motion. So I'm going to start with a case with a 50-year-old lady who was quite active, had a twisting injury because of missing a step 2 weeks back, was initially managed as a sprain, but came back with pain and swelling, especially with weight bearing. And these are the people where somebody comes with a midfoot sprain and they're still painful, they can't walk, alarm bells should be ringing in your ears. Got an MRI done and clearly you can see significant bone edema present, plantar side and the interosseous ligament were torn, and definitely this was like an unstable ligamentous Lisfranc. So what are the options? You can do a fixation, yes, as what Lucky showed, and which preserves the movement. But of course, these patients can have breakage of implant can become loose, and then you may need a second surgery for removal of the implant. And especially the places where we come from, patients don't like leaving broken implants in them, in spite of counseling beforehand as well. Fusion, yes, is a good option, which does not require any second surgery, no breakage of implant. But as also mentioned in literature, you do lose a little bit of mobility, especially in the first TMT joint, and patients again don't like it. So what can we offer? So evolution of fixation options, flexible fixation, where initially you had tightrope, fiber tape was used, then came the internal brace, and also more and more now papers are coming out using autograft or allograft, either in primary fixation or in chronic missed or neglected Lisfranc. So why is it appealing? Because it mimics physiological movement, less hardware irritation, avoids need for removal or a second surgery. Let's look at the literature. Now, this is a literature from 2005 where Vinod Panchbavi and his group looked at 14 cadaveric dissections where the Lisfranc ligament was cut. And they found, of course, that there is significantly more displacement versus both screw fixation or suture button. But interesting what they found, if you do a screw fixation or a suture button fixation, the displacement was equal and it was not significantly different. Another paper, I think somebody else quoted as well, where pure ligamentous Lisfranc injuries presence of flexible fixation has a superior option that better replicates a native anatomy and joint mechanics, while potentially reducing the complications and need for further surgeries. Another paper, a recent paper, showed 12 patients treated with flexible fixation with a young age population. We were able to return to daily activities within a year's time. Also, the AOFA screws improved significantly as well, and the Lisfranc diastasis is reduced from almost 3 mm to 0.14 mm. So actually, it works. Also, a meta-analysis which consisted of 7 different studies incorporated showed that flexible fixation had superiority over an open deduction internal fixation with better AOFA score and return to activities and return to daily activities with lower rates of post-traumatic arthritis, hardware removal, and complications. Also, flexible fixation was better with compared to primary arthrodesis with a higher return to activities and lower rates of hardware removal. But primary arthrodesis demonstrated better pain scores. So, flexible fixation almost equal to or better than ORIF, better or equal to primary arthrodesis. Now, is that enough to make us deal that every patient should be getting suspensory fixation? No is the answer, because biomechanical comparison was done looking at the internal brace fixation, and they showed that there was a 33% failure rate at 1000 newtons if only a single supplementary limb was used. Now, if you reinforce the Lisfranc limb with another supplementary limb, either through an intercuneiform or back to much better. So my indications for flexible fixations are a ligamentous or primarily low energy injuries. There should be no severe bony comminution or displacement. I usually reserve for active individuals or athletes with, as I said, low energy injuries, and they want to desire to preserve joint motion. And again, it's a dialogue between the patient and the physician. When not to use is another important thing which surgeons should be aware. Patients with fracture dislocation with significant bone involvement, comminuted fractures, or gross instabilities, delayed presentation, or chronic Lisfranc injuries, again, may not be susceptible for flexible fixation. And of course, advanced arthritis, you may want to go ahead with a fusion instead of a fixation. So coming back to my case, and as Lucky mentioned, every case you need to screen it. Yes, they come on the table already, that the patient is going to have surgery, but you want to screen it. So here she had a little bit of diastasis seen. I do it in a what we call as a TKL position, where there is a side post. I use a side bottle, and helps me get that positioning and imaging right. That's my incision mark, third, and then a small medial incision as well. And this is where my periosteum, a small periosteum or a McDonald can be used, and that shows that the instability is there. Here you can see the opening. Now beware, these patients, almost 30% of patients with Lisfranc have intercuneiform instability. So that's a very common injury which has been missed, and we should fix that. So in the first stage, I fixed the intercuneiform with a granulated cancellous screw, and then checked again for instability, and it was still mobile, and there you can see opening up as well. Went ahead with the suspensory ligament. Now, a lot of companies have a full kit present. In India, it's also available. Pass a guide wire, drill through it. You have a drill cannulated in the set, and then you pass the tightrope as well. And there you check for fixation, and you see that's your pre-op. And then that's a nice post-op, that the gap has been closed and there is no abnormal mobility present. She went on to do quite well, and here you can almost actively mobilize them with no slam or walker boot, and you can make them weight bear early as well. So summary of the selected studies from literature, Kotsi was the one who started in 2015, showed early outcomes with suture buttons, less hardware irritation, but limited control over midfoot instability. Huang and Chua as well, again, minimally invasive, no hardware removal, but again, short follow-up. And as we saw in the literature from previous speakers as well, you cannot compare all or go through individual studies. You need to look at your own data, how they are doing and what are they doing as well. So in my opinion and my practice, the key thing in suspensory ligaments is preserves the joint motion, early mobilization, selective use possible, but beware, in India also, this whole kit is quite expensive. And if you have comminution of osteoporotic bones, then you cannot use it because button migration is possible. So patient selection is the key. ISO-related, low energy, low BMI patients, compliant patients, I would use a suspensory ligament, while I would use screws or rigid fixation in high energy obese patients. Thank you very much.
Thank you so much, Pradeep. We've had just a few glitches in the connection there, but the message was wide and clear. Lee, you're going to be next with the case discussion. Over to you.
All right, thank you very much for having me here. I'll just spend the next couple of minutes going through a couple of cases to cover the topics that I've covered previously, ranging from flexible fixation to bridge plating as well as fusion. All right, so the first case, we'll start with this 26-year-old male riding motorcycle while holidaying overseas, and at this small accident with the bike falling over his ankle. Presented to the foot and ankle clinic about 3 weeks post-injury, barely walking much. He had some pain while walking barefooted, but was quite comfortable otherwise in a walking boot. So you can see from this, as mentioned by Lucky and earlier speakers as well, there is a mild diastasis between the first and second ray on the right foot. This is one of the views that I commonly get, that was mentioned earlier as well. I'll specify to the radiographer to get a bilateral foot weight-bearing view and specify that it must be done on the same plate, so that the point of view you get from the emitter will be the same, and you can compare the diastasis more accurately. So same thing, you can see it, that's widening, it's a bit of a flex sign as well. So we proceeded with what was described earlier on by Pradeep's talk, flexible fixation. So it includes this pattern on the base of the second metatarsal with a tape that passes through onto the medial cuneiform, and then it crosses on top, above, in between the two intercuneiform areas, and with a screw up the second middle cuneiform. So this is the post-op x-rays. You can see that it's nicely reduced, the space closed up, without much implant that's visible other than the button at the base of the second metatarsal. At 6 weeks post-op, the gap remains slightly closed, and he's walking quite comfortably. So similar to what Pradeep mentioned, usually for this kind of patients, the first 1-2 weeks, I'll keep them in the back slap, non-weight bearing, just for the wound to heal, but thereafter weight bear is tolerated in a long walking boot for up to 6 weeks. And after which we'll wean off the boot and allow sports activity at 3 months post-op. So the second one, slightly different. 7-year-old lady. This patient was actually referred to me from the spine clinic. One of my spine colleagues had spine surgery for her, and she had a foot drop before that as well. So because of the foot drop spine surgery, she had this fall and twisting injury, and got referred to me for this foot pain after that. This was about 4 weeks post-injury. So we saw this was obviously Lisfranc widening. However, at the point of presentation, we wanted to arrange for surgery, and she can't commit until it was about 6 weeks post-injury. So in this state, this case with this slightly chronic Lisfranc injury as well as its older patient, we opted for a fusion procedure for her. So you can see here, this is the CT scan that was done by the spine surgeon prior to referring to me. And this was the fusion procedure we did. This Lisfranc screw holding the first and second ray together, and then 2 nitinol staples with bone grafting in between to fuse up the joint. So this was the post-op x-rays, nicely reduced, staples intact, 6 weeks post-op. And this is 3 months post-op with fusion achieved. So next case, slightly more complicated patient, 49-year-old patient, poorly controlled diabetic, multiple social issues as well as this alcoholic liver cirrhosis. Came in, presented to the emergency department with bleeding GIT, and he had a fall at the same time. So his bleeding GIT was resolved and was referred to us. So he came to our clinic about 2 weeks post-injury. You can see this fleck as well as multiple basal metatarsal fractures. We did a breech plating, as was mentioned before. The first TMTJ was deemed to be stable, so it's nice, sleek thin plates over the second and third TMTJ. And he was kept on a non-weight bearing ambulatory regime. But as can be seen with his antisocial personality issues, he was obviously non-compliant. So before the union of the bones and the scarring could take place, he walked on it uncontrolled, and the plate obviously broke apart. For various reasons, due to his liver cirrhosis, non-compliance, and non-return hospital, we eventually saw him again 1+2 years down the road with persistent midfoot pain, stable implant failure as well. At that point in time, he was seen by gastro and deemed to be fit for surgery. And we proceeded with revision, and this time we fused up the joint. 2 staples as well, 4-prong and 2-prong staples. I found that with this staples, the fixation was quite stable. I didn't have to add additional Lisfranc screw, and it was stable in the intercuneiform as well. So this time around, he claimed to be compliant, and this is 3 months post-op. The implant's holding well, and the fusion seems rather stable as well. So the last one, just to end it off, slightly higher trauma, patient, 50 years old, motorcyclist, right foot open fractures, multiple MT base fractures, as well. You can see the soft tissue loss and shadow on the X-ray. These are the CT scans. This is the wound post-debridement with open Lisfranc injury and stripping of the dorsal capsules. So we worked with the plastic surgeon once the wound was clean and nice, did a bridging plate for the first TMDJ as well as the second with the Lisfranc screws. And plastics, this was this was the X-ray on the 6 weeks holding stable. And this is the clinical image and X-rays at 3 months with this big flap over it covering over the joint. So there was some mention about removing of bridging plates, but in such a case, you have to have a very close discussion with the patient as well as the plastic surgeon, because this would involve elevating the previous flap once it's mature and then removing the implant. So there's always an option to leave it, let it break, as long as the patient understands that there will be broken implant, but that shouldn't affect his ambulation and mobility. So these are his final X-rays. So laying point, the Lisfranc comes in various shapes and sizes. Treatment options needs to be catered to individual conditions as well as the patient portfolio before we decide on what's the most optimal treatment for them. All right, thank you.
Thank you so much, Lee, for those 3 interesting cases. As you mentioned, these injuries come from span from simple, straightforward or pure ligamentous injuries to devastating injuries. Right, so we've gone through the anatomy and of the foot, as mentioned by Mai, and then we've gone through the assessment and examination. We all know that these injuries can be easily missed if not thought of, and a thorough examination has been done. And the importance of surgical intervention, length and alignment, like Lucky said, length and alignment, that's a really good way to put it. And then fusion versus ORIF, and an interesting concept of gastrocnemius lengthening in these injuries. And when, how, and when not to use flexible fixation, as Pradeep has mentioned. We can open the floor for any questions. Are there any questions from the audience? Let me just have a look. Okay, I think we're gonna close it. If Sufyan is here, I'm going to be putting this slide for the feedback for the webinar. Can you see it, everyone?
Yeah.
Is it visible?
Yeah.
Okay, so I'm going to just leave it on for a couple of minutes. And quick question to Pradeep. So, do you suggest, or do you think that the intercuneiform stabilization is done better with a suspensory fixation or a screw fixation? Because I think that's you've outlined a very important point here about the intercuneiform instability.
So I did not put the other case. So recently I did another suspensory ligament, again, a very low grade injury, very low energy injury, patient complaining of pain at 6 weeks time. And I thought I would be able to do it. The point is, if you have to do an intercuneiform, that's a big dissection. So like if you do a percutaneous screw, intercuneiform is not an issue. But if you're doing an intercuneiform flexible, you have to open it up, you have to go over the top, and then you have to use multiple swivel locks on the medial cuneiform and intermediate. So that is a bigger dissection. And I think, yes, you could do it, but just use a screw. But there are definitely lots of papers describing it. There's a lot of papers coming from China where they have used allografts and tendons around it in chronic cases, and they've done well.
Okay, so you suggest that whenever you see a pure ligamentous injury, you recommend testing the intercuneiform for instability and a percutaneous screw.
I think any Lisfranc for that matter, I think you always have to test for intercuneiform. Even the Lisfrancs, which I think all the eminent faculties have shown, there's a 30 to 40% chance of intercuneiform instability. So I think you should. And if in doubt, fix it.
Do you remove those screws? Have you seen any incidents of breakage of that intercuneiform screw?
No, I haven't seen any breakage of intercuneiform screws. But I'm a very big proponent of fixation. I don't know primary arthrodesis. And I know Lucky mentioned that they've looked at the studies and there is no, you can leave the screws for fixation, leave it for hardware removal. But I tell my patients, and especially Indian population, they do not like breakage of implants. So it's better warn them, and at 6 months I remove them.
Has anyone come across a broken Lisfranc screw?
Yeah, I have, Moez. And I was going to say that, I think one thing we didn't talk about is there is some movement between the columns. So if you think about it, that medial column has about 5 to 10 degrees of movement. And so that medial column is always trying to move against the rigid middle column. And so you've got a screw going across it. And when we leave metalwork in, we do see screw breakages. And interestingly, often patients feel a bit better once the screw breaks because they feel like they've got a bit of mobility. Yeah. And that's what's interesting. I wanted to add one comment about suspensory ligament reconstruction. Very similar to the ankle, I always worry a little bit about control of longitudinal or dorsal displacement, right? So in the same way that, we worry if you've got an unstable length in your fibula, you wouldn't necessarily use tight ropes. So I often worry that in a Lisfranc, we see dorsal displacement of the metatarsals. And so I again worry that if we use suspensory ligament fixation alone, what we may see is some dorsal displacement. I don't know how well controlled that dorsal displacement is, but where I use suspensory ligament fixation is instead of a Lisfranc screw. So I'll do my dorsal bridge plates. So I've got that control of dorsal subluxation. And then I use a tight rope instead of a screw, which allows a little bit of movement between the columns, which is, I think, quite an important part of how well patients do.
Yeah. So again, you can look at the other way around. You can do a suspensory ligament, and then you find that there is instability, put a plate on.
Yeah. Equally balanced.
Okay. Yeah.
And regarding the concept of primary fusion, I agree. These can be really, really difficult. You have a smashed up base of metatarsal. You've got a big void. I haven't found them easy at all. I'm not quite sure about the experience of the others. If anyone agrees or disagree.
I mean, one of the issues when you're dealing with a fracture situation is, we know that in fusions, generally you need some compression to get the healing. And one of the problems with the fracture situation is that putting compression across a fracture will often cause some sort of collapse. So quite often I will tend to use fully threaded screws across joints as well that I'm fusing, because that will allow some stability, but it doesn't give you the compression that will cause collapse.
And just a quick question to Amit or to everyone about, we come across these injuries a lot, and you come across those extra-articular fractures of the bases of the metatarsal. And I'm not quite sure if you call these Lisfrancs. These are just metatarsal base fractures. And a Lisfranc has to be an intra-articular injury, if I'm not mistaken, isn't it?
Yeah, I think you need to be suspicious if you've got an extra-articular fracture close to the joint. I think you should be screening the joints around there to see where the energy gone when they've had that injury. And I think, honestly, the reorientating CTs is really important. And often I find injuries that I didn't see on the X-ray. And if you reorientate them, you can see actually where there's subtle avulsions and subtle dislocations and subluxations, which, you end up having to fix, and you end up having to fix that base metatarsal fracture as part of that as well to get stability in all the columns.
Okay, I think we're a bit over time here. One final question: is there any role for conservative treatment in these injuries? Any role?
Well, I think in the odd patient with their comorbidities don't allow, or for other, maybe polytrauma kind of reasons, I may not fix a subtle Lisfranc that I would manage non-weight bearing, and then at maybe 3 months convert them into a shoe with a good orthotic. But I think having seen so many myths that come back, I think we need to think about doing something, even if it's minimal, to try and reduce that.
Wonderful. Thank you so much, everyone, for a really interesting webinar, and I hope you all can join us in our third webinar, which will be in August on Achilles pathologies. Thank you so much, and have a great evening.
Thank you. Yes.